Welcome, you are listening. Today we are strapping into the operating room, metaphorically speaking, and taking the scalpel to the meniscus. That structure inside your knee that's, well, frequently injured, often misunderstood, but critically important.
Absolutely.
This deep dive is really designed as an intensive pre-op radiological consult. Think of it as a masterclass in reading the images that, dictate our surgical plan.
It is exactly that. We're decoding the meniscal tear, moving beyond just simple descriptions to really understanding the biomechanical failure that the images represent.
Right.
If we think about the knee as this fine piece of machinery, the meniscus is kind of like the most stressed gasket and the critical shock absorber, all rolled into one.
And it's the one that always seems to blow out at the worst time, doesn't it?
It often feels that way, yeah.
Yeah.
The scale of the problem is just enormous when you look at it.
It really is. Look at the volume we deal with. I mean, the sources indicate that in the U.S. alone, something like 1 million arthroscopic partial meniscectomies are performed annually.
1 million.
Yeah, that figure, drawn from the literature, it just shows this isn't just common pathology. It's a foundational piece of orthopedic practice.
And that volume really underscores the gravity of our mission today. We're looking at this because the consequences of getting the diagnosis wrong or delaying treatment, they can be severe. We know from clinical studies that abnormal biomechanics following a meniscal injury immediately expose the underlying articular cartilage to these high-focused stresses.
Right, concentrating the force.
Exactly. And this exposure accelerates lesions. It leads directly to early osteoarthritis, or OA. So our goal here is to leverage prompt, accurate diagnosis using MRI, magnetic resonance imaging, to reduce that long-term morbidity for the patient.
So MRI then is our preoperative preservation map, basically.
That's a great way to put it.
It's the modality of choice, confirmed across multiple sources for its high sensitivity, high specificity in detecting and characterizing these injuries. But, it's not enough just to order the scan. We actually have to speak the language of the image.
That's the critical distinction, isn't it? Our mission is to bridge that gap between, say, the dark signal on the T1 sequence and the three-dimensional, potentially catastrophic failure of the joint's engineering.
Yeah.
We need to internalize the imaging signs so thoroughly that when we see a displaced fragment, we immediately visualize the patient's locked knee and, well, the necessary mechanical fix. Okay, so to understand the pathology of the problems, we first have to master the normal blueprint.
Makes sense.
The menisci are these complex C-shaped fibrocartilaginous pads. They sit between the convex femoral condyles and the flatter tibial plateau. Think of them as load-distributing wedges.
But they're far more than just spacers, right? I mean, what are we actually losing when this structure fails?
Well, you lose 6 primary functions, according to our foundational sources. They're crucial for 1, load distribution, 2, acting as immediate shock absorbers, 3, increasing the contact area, the congruency between the femur and tibia, 4, enhancing joint stability, and 5 and 6, aiding in joint lubrication and even nutrient distribution.
Wow, okay, so a lot.
A lot. If any of those functions fail, maybe due to mechanical disruption or loss of tissue, degenerative change isn't just a risk anymore.
Yeah.
It's pretty much a guarantee.
And anatomically, we're defining them as these elongated semilunar triangles, right? Segmented into the anterior horn, the body, and the posterior horn. Those are the 3 regions we've got to identify on every sagittal slice.
Absolutely. And just as important as the body itself are its anchor points. The strongest attachments to the tibial plateau are the anterior and posterior meniscal root ligaments.
Okay.
These are non-negotiable stabilizing structures. If you lose the root, you basically lose the mechanical function entirely. This concept, the root being paramount, it's going to be a recurring theme because, well, injury to these ligaments is functionally equivalent to a total meniscectomy.
Got it. Crucial attachments.
Okay.
Now, let's delineate the 2 menisci, because clinically and structurally, they're really quite different players, aren't they? Let's start medial. It's got that wide open C shape.
That's right. And if you look at the medial meniscus in cross-section, say on an axial slice or maybe a coronal view, it's not a uniform wedge. The geometry is specific. The posterior horn is structurally twice as large as the anterior horn.
Twice as large. Okay.
Yeah, it's a bulky structure, kind of built for bearing heavy static loads.
And it's the less agile cousin, you could say. It covers a smaller percentage of the total tibial articular surface, usually around 50% to 60%. But the key, like you noted, is its tight stability profile. It's almost entirely glued to the joint capsule.
Precisely. Its stability comes from that extensive capsular attachment, and it's reinforced by the supporting ligaments, the meniscocapsular ligaments, the meniscofemoral ligaments, and those short meniscotibular coronary ligaments.
Right.
Because it's so tightly bound, it's less mobile.
Yeah.
And that's actually why it tears more easily, especially posteromedially. It just can't escape the shearing forces as well.
Okay, that makes sense. Now, as the resident perspective, when we're looking specifically at the anterior root ligament of the medial meniscus, the textbooks describe, 4 specific insertion patterns.
That's right.
Type I is the most frequent, I remember that. And type phi involves no bony attachment at all. The sheer variability here means that stability really starts with the anatomy of the attachment itself. If the meniscus isn't anchored securely, like maybe in that type 4, it's inherently more predisposed to micro-instability and, well, eventual tear.
That's a great point. Now, compare all that to the lateral meniscus. This one is more like the dynamic acrobat of the knee.
Okay.
It's a more rounded, closed C shape, almost a circle. And its wedge morphology is far more uniform across the anterior and posterior horns.
Counterintuitively, though, even though it's often smaller overall, it covers more tibial surface area, right? Up to 70%. That suggests better contact mechanics when everything's intact.
It does. But the crucial differentiator, the really key difference, is its attachment, or rather, lack thereof, posterolaterally. It's only attached to the capsule anteriorly and then way back posteriorly.
Why the interruption then?
Because the popliteal hiatus exists. The popliteus tendon actually passes right through a gap in the capsular attachment, right at the level of the body and posterior horn.
Ah, okay. That structural interruption gives the lateral meniscus its great mobility. You mentioned it moves 9 to 11 millimeters in the AP plane versus the medial meniscus is maybe 2 to 5 millimeter.
Exactly.
But it also creates a vulnerability, right? That posterolateral corner becomes this anatomically complex region, and it's a frequent source of imaging pitfalls, which I'm sure we'll get into.
We definitely will.
Right.
It's that anatomical tightrope walk. The mobility helps it dissipate energy, sure, but the hiatus means it lacks the solid circumferential stability you see on the medial side.
Okay, let's shift focus a bit down to the microstructure. If the meniscus is this critical load-bearing structure, its composition must be key. It's high in water, you said, about 72%, and highly fibrous, with 75% type I collagen.
Correct.
And we absolutely have to talk about the 2 functional zones defined by vascularity, the red zone and the white zone.
Yes. These zones basically determine our repair strategy in the OR. You've got the peripheral 20% to 30%, which is the vascularized red zone. That's the area with healing potential. That's the repair zone. Then you have the inner 2/3, the avascular white zone. That tissue, well, it doesn't heal effectively on its own. So the line between repair and resection often runs right there, between the red and white zones.
But the real genius, you could say, is in the architectural layout of the collagen itself. It's like this beautifully designed fibrous net.
It really is. We sometimes talk about 3 layers, but the central main layer is the functional heart. It's comprised of these huge bundles of collagen fibers oriented circumferentially. Think of them running parallel to the longitudinal axis, like the steel bands around an old wooden barrel.
Okay, like hoops.
Exactly, like hoops. And these are tied together by smaller radial tie fibers that travel perpendicularly, kind of holding the hoops together.
Okay, so let's unpack the mechanical magic that happens when these fibers meet that axial compression. The whole structure is basically designed to deal with the inevitable crushing force of the femur pushing down on the tibia.
Precisely. When you stand up, and those axial forces, that vertical compression comes down, the meniscal wedge naturally tries to extrude, to squish out laterally immediately.
Right.
But those circumferential collagen fibers, those hoops, resist that extrusion. They brilliantly convert the vertical compressive load into tensile stresses along the axis of the meniscus itself. That tension is what we call hoop stress.
So, if the knee is the barrel, the meniscal fibers are the tight steel hoops keeping it together. And if the hoops are intact, the barrel doesn't explode under pressure.
Perfect analogy.
And the meniscal roots, then, are the ultimate anchor points, preventing the entire hoop structure from just slipping off the barrel, off the tibia.
That's exactly it. As long as those roots are intact, they resist the tendency of the hoop to pop off the tibial surface. This mechanism is incredibly efficient. It's how the meniscus manages to transmit, 50% of the load in the medial compartment and up to 70% in the lateral compartment.
Oh.
Losing that load dissipation ability is exactly why a failed meniscus rapidly destroys the articular cartilage underneath.
And this also circles back to mobility, doesn't it? The medial side, being more constrained, less mobile, only moving 2 to 5 millimeter, experiences higher fixed hoop stress. Whereas the more mobile lateral side, moving 9-11 millimeter, can absorb and redirect stress more dynamically.
And that low mobility on the medial side explains our most frequent tear location, the posteromedial portion. It's constrained by the posterior oblique ligament. It can't get out of the way, and that's where shearing forces tend to win out. Hashtag 1.4, the meniscectomy downfall.
You know, the history lesson here is actually essential. We have to remember why we're so focused on preservation today. It goes back to, 1948? Fairbank described the degenerative changes that followed total meniscectomy.
Yes, a seminal moment. It really shifted the entire practice paradigm from routine resection towards repair whenever possible.
It must have been a brutal realization back then, but the physics supported it completely. If you remove the shock absorber and the load distributor, well, the pressure gets concentrated, right?
Absolutely. The data is stark. After total meniscectomy, the contact area between the femur and tibia decreases by 50% to 75%.
Half to 3/4 less area.
Yeah. And the contact pressure simultaneously increases 2 to 3 times.
2 to 3 times the pressure. That is exponential force concentration. That's the definitive so what for you, the listener. Increased load leads directly to catastrophic cartilage injury and degeneration.
Yes.
This is the rationale, the absolute ethical mandate, really, driving us to prioritize preservation and repair over resection whenever the tissue allows for it.
And even if we must resect, we have to be surgical conservationists. Studies consistently show that the amount of tissue excised is inversely related to the functional outcome.
Less taken out, better outcome.
Exactly. Specifically, patients who undergo large resections of the posterior horn, that key load-bearing area we talked about, they have the worst long-term functional results. Every millimeter of healthy meniscal tissue saved is potentially a year or more added to the lifespan of that knee joint. Okay, let's translate this complex anatomy into the language of the magnetic field, into what we see on the MRI screen. The key baseline is signal intensity. The normal meniscus is uniformly hypointense. That means dark or low signal on both T1 and T2 weighted MR images. This is primarily due to the short T2 relaxation time caused by those dense, highly aligned type I collagen fibers we discussed.
So dark is normal, bright signal is suspicious. We're fundamentally looking for an aberrant signal intensity that isn't that normal dark signal of healthy fibrocartilage.
Pretty much. The only acceptable exception, really, is maybe some peripheral high signal in younger patients due to normal vascularity in the red zone, which is why clinical correlation is always required. You can't just read the image in a vacuum.
Good point.
And the morphology, the shape, changes based on your viewing plane. On axial images, you see the open C medially and the closed C laterally. When you cut perpendicular to the long axis, so sagittal slices for the horns or coronal slices for the body, you get that classic triangular or wedge shape.
But the most crucial view, I'd argue, for detecting displacement is the sagittal image right through the meniscal body, where it should present as the bow tie configuration.
Absolutely key sign.
If you see a full bow tie, that section of the meniscal body is likely intact and in place. But if you lose that bow tie across 2 consecutive slices, well, then you have to strongly suspect a massive displacement, like a bucket handle tear.
Exactly right. And always be mindful of the normal differences in horn size on those sagittal sections. Lateral horns are generally similar in size, while the posterior horn of the medial meniscus, remember, is often twice as large as the anterior horn.
Yeah.
If you mistakenly diagnose that normal posterior bulk as, say, edema or early pathology, you risk a false positive reading. Got to know your normal anatomy cold. Hashtag 2.2 essential imaging sequences and optimization.
Okay, so as the surgeon or the referring clinician, we need to know the recipe for the best possible images. We're hunting for millimeter-sized defects here. Which plane gives us the best view generally?
Statistically, the sagittal plane is king. Sources suggest up to 97% of medial tears and 96% of lateral tears are best identified in this plane.
Wow, okay. Sagittal first.
Definitely. When selecting the sequence, we heavily favor proton density PD sequences. These offer the best contrast between the hypointense, dark meniscus, and the high signal, the bright signal, of the fluid or degeneration that fills the tear cleft.
And we lean heavily on FSC, fast spin echo, right? Mostly to capture the image quickly and minimize patient motion artifact, especially with non-sedated patients who might wiggle.
We do, but FSC comes with a huge technical trade-off. image blurring.
Ah, right.
That blurring can actually smooth over the high signal line of a subtle tear. It can turn what should be a clear grade 3B tear into something that looks more like a benign grade 2 lesion.
Not good. So how do we combat that blurring?
That's the compromise we have to manage. To counteract FSC blurring, we must insist on specific parameters from our radiology colleagues or techs. We need low echo train lengths, ideally 4 or less, and high bandwidths, maybe in the 30s or higher.
Okay.
This technical optimization helps ensure that the fibrocartilage margins remain sharp and that subtle tears aren't just masked by hardware limitations or poor sequence choices.
And when dealing with structures this small, the meniscus averages maybe 8-10 millimeters in thickness. High spatial resolution is absolutely non-negotiable, isn't it?
Completely non-negotiable. That means a small field of view, FOV, 16 centimeters or less ideally, thin section thickness, 3 to 4 millimeters, not 5, and a high matrix size, at least 192 by 256, preferably higher.
Because if you're reading a report based on 5 millimeter slices, you could be flying blind on subtle radial tears, for example.
Indeed, you're just averaging too much information in that thicker slice. Regarding magnet strength, 3T machines offer higher signal-to-noise ratios, which sounds appealing, and the images can look prettier.
Right.
But they also increase sensitivity to artifacts, like chemical shift and susceptibility effects, which can sometimes mimic pathology. While the image quality might look superficially better, the actual diagnostic accuracy remains pretty comparable between optimized 1.5T and 3T systems for meniscal tears.
So don't rely on the magnet strength to compensate for poor technical sequencing.
Exactly. Good technique trumps brute force magnet strength here.
Okay, the diagnosis really hinges on that signal intensity extending to the surface. Let's just quickly review the classic grading system, because this is where ambiguity often creeps in, right?
It can, yes.
Yep.
The primary diagnostic criterion is a linear intrameniscal signal intensity that clearly extends to and contacts an articular surface. That contact is the key. It signifies the communication, the mechanical breach.
Okay, let's nail the grades down, especially the distinction between what's pathology and what's just aging.
Right. Grade 0 is our baseline. Uniformly low signal, nice and dark, normal.
It's normal.
Grade 1 shows some globular or ovoid high signal, but it's entirely contained within the meniscus. Crucially, it does not touch the surface. This is generally considered benign, just early degeneration or maybe some vascularity.
Okay.
Grade 2 is a linear or wedge-shaped signal, again, confined to the center and not communicating with the surface. This is also typically intrameniscal degeneration. It's really important to remember. We generally don't operate on grade 1 or grade 2 findings. Those are observations of wear and tear, not necessarily surgical lesions.
Got it. So the surgical pathology is grade 3B.
Exactly. Grade 3B, that's intrameniscal signal that clearly contacts one or both articular surfaces, superior or inferior. If it touches the surface, that is a mechanical breach, and that is a tear that needs clinical correlation. Grade 3A, by the way, refers to sort of equivocal signal contacting the surface, which is usually disregarded unless there are other strong findings.
Okay, 3B is the money grade for a tear.
Pretty much.
Yeah.
And to increase diagnostic confidence, especially with subtle findings, we rely heavily on the two-slice touch rule.
Yes, the two-slice rule.
This rule basically states that a tear is highly probable if you see that signal abnormality contacting the surface in 2 or more consecutive MR images. This is a crucial defense against mistaking partial volume averaging or subtle artifacts for a true tear.
And the data supports this defense, which is why it's become such a common rule of thumb, right? Studies show it significantly boosts the positive predictive value for medial tears, moving it from maybe 91% up to 94%, and even more dramatically for lateral tears, jumping from 83% up to 96%.
It does. It's a good mechanism for minimizing unnecessary arthroscopy based on equivocal single-slice findings.
However,
we must remain vigilant. False positive diagnoses still happen. They're most common in the medial meniscus and often associated with the tear types that are actually hardest to spot arthroscopically sometimes, like longitudinal, radial, and especially root tears. The anatomy of that medial side, particularly the posteromedial curve. Yeah, well, we can put a magic angle effect later.
so why do menisci tear in the first place? We know the prevalence increases with age, and it correlates heavily with pre-existing degenerative joint disease, osteoarthritis.
True.
But the mechanism of injury often dictates the pattern we actually see on the MRI.
It does. We generally classify the mechanism into 2 main buckets. First, you have traumatic tears. These occur when excessive force acts upon normal, healthy tissue. Think acute athletic injuries like a pivot shift. These typically result in radial or vertical tear patterns. Conversely, you have degenerative tears. These arise from normal, everyday, repetitive forces acting upon tissue that's already weakened and degenerated over time.
Like getting out of a car.
Exactly. And these almost always present as horizontal cleavage tears.
And the most vulnerable spot, we've kind of highlighted it already, haven't we? It's the posterior horn, particularly the medial posterior horn. That's the most frequently injured site.
It is. It's relatively immobile compared to the lateral side, and it gets subjected to high compression during flexion and rotation.
Makes sense.
The poor mobility prevents it from translating out of the way of the compressing femoral condyle. So, knowing the etiologies helps us predict the pattern we should be looking for. If we see a horizontal cleavage tear in, say, a 65-year-old who certainly felt a twinge getting out of a chair, we immediately think degeneration.
Right.
If we see a vertical tear in a 20-year-old soccer player who planted and pivoted, we think trauma. Hashtag 3.2, longitudinal horizontal tears, the cleavage plane.
Okay, let's start with the most common degenerative pattern then. Longitudinal horizontal tears. These are those cleavage planes running parallel to the tibial plateau. They essentially split the meniscus into a superior and an inferior flap.
These are often called fish mouth tears because of how they look sometimes. Crucially, they primarily separate the circumferential collagen bundles rather than violating them entirely, meaning the primary hoop strength, theoretically at least, remains intact, especially initially.
Okay.
They are the classic finding in individuals over 40, often without a specific acute trauma history, just gradual wear and tear.
And on the MRI, we see that unmistakable horizontal hyperintense line, right? Often extending from the inner edge out toward the periphery, visible on both sagittal and coronal images usually.
Yep, that's the look.
Because this tear pattern creates two flaps, these are often the tears we end up managing with simple debridement, just shaving off the unstable portion, as the remaining peripheral rim is usually pretty stable.
That's often the case. And this care type has a really important associated finding we need to look for: parameniscal cysts.
Ah, the cysts.
Yeah. The dominant theory is that the joint fluid gets forced out under pressure through that horizontal cleavage plane. It acts like a one-way valve or a hydraulic pump, and the fluid accumulates outside the joint capsule, forming a cyst.
So the cysts are a key clue, and they're almost twice as common in the medial compartment, right? Because the medial side is less mobile, creating higher pressure differentials.
Exactly. But there's a vital exception here that you need to remember. Cysts adjacent to the lateral anterior horn are usually not associated with an underlying meniscal tear.
Oh, interesting.
Yeah, it's a point of differentiation. So medial cyst, definitely look hard for the horizontal tear. Lateral anterior cyst, it's often just a degenerative fluid collection, maybe related to the transverse ligament, not necessarily a tear.
Good pearl. Medial cyst, it's tear, likely. Lateral anterior cyst, maybe not.
Right, and let's emphasize size, too. Medial cysts tend to be larger and can expand more dramatically as they penetrate the capsule, sometimes tracking quite far posteriorly. We have to be careful not to mistake a large posteromedial parameniscal cyst for a popliteal cyst, a bigger cyst which has a different origin and different management. Hashtag 3.3, longitudinal and vertical tears, the split.
Okay, moving on to the more traumatic profile. Longitudinal vertical tears. These run perpendicular to the tibial plateau along the anterior-posterior axis. They basically split the meniscus into a central portion and a peripheral portion.
Right. Imaging typically shows a hyperintense vertical line contacting one or both articular surfaces. Because these often occur closer to the periphery, sometimes in that vascularized red zone, they are potentially far more amenable to surgical repair compared to those degenerative white zone horizontal tears.
And there's an incredibly strong statistical relationship here, isn't there? You really can't look at a peripheral vertical tear without simultaneously assessing ligament stability, especially the ACL.
Absolutely critical connection. Sources confirm that something like 90% of medial and 83% of lateral peripheral longitudinal tears are associated with the concurrent ACL tear.
Wow, 90% and 83%. They're basically comrades in trauma.
They really are. And that comorbidity actually makes the MRI interpretation challenging sometimes. Tears associated with an acute ACL injury can be difficult to detect because the trauma often causes a massive joint effusion, maybe hemorrhage, which changes the signal characteristics in the joint and can obscure subtle tear clefts. Our sensitivity for picking up these associated meniscal tears definitely drops in the acute ACL setting.
That makes sense. Lots of fluid and blood obscuring things. Now, one particularly fascinating and high-risk variant associated with acute ACL injury is the Risberg rip. Can you explain that one?
Ah, yes, the Risberg rip. This is a specific tear occurring right at the junction of the posterior horn of the lateral meniscus. It's thought to result from the extreme traction exerted by the ligament of Risberg, one of the meniscofemoral ligaments, as the tibia translates anteriorly in the ACL-deficient knee.
So the ligament itself rips the meniscus attachment.
Essentially, yes. It's a sign of significant instability, and it definitely requires prompt surgical attention. It really speaks volumes about the immense forces at play during an ACL rupture. If the ACL fails, the biomechanics are instantly derailed, and the secondary restraints, like the meniscofemoral ligaments, end up potentially tearing the meniscus in the process of trying to compensate. Hashtag tag 3.4 radial tears, the structural killer.
Okay, if the horizontal tear is maybe a slow aging failure, the radial tear is more like a violent mechanical execution. These run perpendicular to the longitudinal axis, slicing right across the breadth of the meniscus. They account for maybe 15% of tears overall.
Around that, yeah. And they are the structural killer because they critically and completely violate the circumferential collagen bundles.
They cut the hoops?
They cut the hoops. This is the anatomical equivalent of taking shears to those steel bands on the barrel. The moment those bundles are breached longitudinally, the hoop stress mechanism just collapses.
So when a radial tear is complete, meaning it extends all the way to the periphery, the functional outcome is pretty disastrous, right? Hoop strength is immediately lost.
Instantly lost. And that leads directly to meniscal extrusion, the meniscus getting squeezed out of the joint, and the effective functional death of that part of the meniscus. This is why we often equate a complete radial tear with a functional total meniscectomy in terms of biomechanical consequence.
Oof. Clinically, these are also nightmares to image and diagnose accurately, aren't they? They're often missed on conventional MRI, accounting for a large chunk of false negatives. Why is that?
It's mainly because the tear runs in an orthogonal plane, perpendicular to the main circumferential fibers. This plane might not align perfectly with our standard sagittal or coronal imaging slices, so you might only see a tiny dot or a subtle line on one slice. They often defy that handy two-slice touch rule.
So since direct visualization can fail us, we have to rely heavily on secondary signs. What's our checklist for spotting the potentially invisible radial tear?
Okay, good question. First, look for the truncated free edge sign on coronal images. Instead of that normal sharp concave inner margin, you see a squared off, blunted edge where the tear runs through the tissue to the free edge.
Okay, blunted edge coronally.
Second, the blunted bow tie sign on sagittal images. The normally nice convex shape of the bow tie looks compressed or truncated vertically.
Got it.
But the most specific sign, although it often requires careful multiplanar assessment, is the ghost meniscus sign.
The ghost sign, I like that name. What is it?
That's where you're looking at the sagittal slices, right where the meniscus body or horn should be clearly visible. But instead of seeing the normal dark tissue, you see either minimal tissue or just this diffuse high signal intensity. It's because your imaging plane is running directly along the axis of the radial tear itself.
So the tear is essentially lined up perfectly with the slice, making the meniscus tissue seem to disappear.
Exactly. It's the tear hiding in plain sight, so to speak. If this kind of tear occurs in the avascular white zone, debridement, just cleaning it up, is often the only surgical option, since repair is usually futile due to the lack of healing capacity and the catastrophic disruption to the structure.
Okay, moving into displaced tears. These demand immediate clinical attention, right? Because they typically cause acute joint locking, mechanical symptoms, significant pain. The bucket handle tear is the most frequent type of displaced injury we see.
It is. This is a specific type of vertical or oblique longitudinal tear, where the detached inner fragment, we call it the bucket handle, displaces entirely from its normal position.
And it's significantly more frequent medially, correct? Something like 7 times more frequent than laterally.
That's the statistic, yes. The displaced fragment flips, often into the intercondylar notch, right between the femoral condyles, or sometimes it flips anteriorly in the joint. This flipped fragment is what mechanically blocks the knee movement, causing that locked sensation.
So when we're reviewing the sagittal MRI, we have, 4 classic signs that act like breadcrumbs leading us to the diagnosis. The first one is the highly reliable double PCL sign.
Yes, the double PCL, primarily seen in medial bucket handle tears. It appears as this distinct band of low signal intensity, dark signal, running anterior and parallel to the actual posterior cruciate ligament. It literally looks like the PCL has acquired a buddy, a twin.
But that buddy is actually the displaced meniscal fragment, just sitting there kind of cuddling the PCL.
Exactly, snuggled up right against it.
Okay, what's the second sign? Often associated with lateral tears, I think.
That would be the fragment and notch sign. Here, the low signal band of the displaced fragment is located squarely in the intercondylar notch, sometimes seen on slices that are separate from the PCL itself. It's just sitting there in the middle of the joint.
Makes sense. Third sign, what if the fragment flips forward?
If the fragment flips anteriorly, we look for the double anterior horn sign. This is when the displaced fragment is seen immediately posterior to the actual normally located attached anterior horn. It effectively makes the anterior horn look twice as thick or doubled up.
Okay.
If the fragment flips superiorly over the anterior horn, we sometimes call that the less common flipped meniscus sign.
Got it. And finally, the indirect evidence of displacement is also key. The absent bow tie sign.
Crucial indirect sign. If you lose that normal bow tie appearance of the meniscal body on 2 consecutive sagittal slices where the body should clearly be present, well, it strongly implies the main central fragment has displaced somewhere else. The remaining peripheral rim is just too thin to register as a full bow tie anymore. This is often the very first clue that makes you hunt for the displaced piece. Tag 4.2 displaced flap tears, the parrot beak. Next up, we have the displaced flap tears. These are more complex injuries that extend in more than one plane, creating separate flaps or tongues of meniscal tissue. They make up nearly 1/5, maybe 19% of symptomatic meniscal injuries.
I always like the analogy of a Schroman's sail for these. The flap is now loose. It's catching the currents of the synovial fluid, causing instability, catching, and pain.
That shredding analogy is pretty apt, actually. Specifically, an oblique radial tear that has a displaced flap associated with it is commonly labeled a parrot beak tear.
Parrot beak?
Yeah.
Why that name?
The term is used because the free edge of the flap is often curved and looks somewhat thick on imaging, vaguely resembling the beak of a parrot. They're also slightly more common on the medial side.
Okay. The clinical relevance of these flap tears, especially those that displace inferiorly underneath the main body, cannot be overstated, can it? Why is the inferiorly displaced flap such a particular nemesis in the operating room?
Because they are typically invisible at standard arthroscopy. Well, very hard to see. The flap gets tucked down into the meniscotibial or coronary recess, hiding beneath the femoral condyle, especially when the knee is flexed during scope insertion. If you rely solely on your arthroscopic examination without a detailed roadmap from the pre-op MRI, specifically flagging that hidden flap, you will miss a crucial piece of pathology. And that missed fragment will likely continue to cause mechanical symptoms postoperatively.
So the MRI absolutely has to flag these hidden inferior fragments.
It must. Similarly, superiorly displaced flaps, often located anteriorly, can also be tricky to visualize sometimes on standard coronal images due to volume averaging effects. Careful scrutiny is needed. Tag 4.3 root ligament tears, functional meniscectomy.
All right, let's talk about the root tears. These are really the definition of high morbidity pathology when it comes to the meniscus. When the meniscal root ligament fails that critical anchor holding the hoop structure to the tibia, the entire structure basically ceases to function biomechanically. The complete loss of hoop stress is instantaneous.
This is arguably a limb-threatening diagnosis, certainly a joint-threatening diagnosis in terms of long-term joint survival. Functionally, a complete root tear is identical to a total meniscectomy, and it drives rapid, almost predictable acceleration of OA progression.
And the posterior horn root of the medial meniscus is the primary culprit here, right? With incidence rates reported between 10% and 21%, it's the least mobile anchor point, absorbing enormous strain.
Exactly. It bears the brunt. Conversely, lateral root tears are far more often seen secondary to concurrent acute ACL tears, typically due to the extreme rotational and translational forces involved in that injury mechanism.
Okay. Given the absolutely devastating consequences, we have to be absolutely certain in our imaging diagnosis of a root tear. These are typically radial-type tears occurring within about 1 centimeter of the tibial attachment site. What are the specific signs we need to look for?
We look for a combination of signs. First, sometimes you can see a frank fluid cleft, a bright line visible in the coronal plane, cutting right through the attachment zone.
Okay, fluid cleft coronally. What about on the sagittal cuts, where visualization is often said to be best for the roots?
On sagittal views, we look for the truncation sign. This is a clear, vertical, linear defect interrupting the normally continuous fibers of the root ligament itself, seen right at the bone meniscus interface.
Okay, truncation.
But perhaps most damning is the return of the ghost meniscus sign, specifically at the root insertion. This indicates that the normal dark root tissue is either absent or replaced by this diffuse high signal intensity, likely due to the tear itself and surrounding edema or fluid. Seeing that high signal replacing the expected solid black signal of the root means the anchor attachment is gone.
Wow. The moment we see this constellation of findings, we're dealing with a critical joint salvage situation, aren't we? The treatment mindset immediately shifts from maybe a minor debridement to a much more complex fixation procedure, aimed at restoring that anatomical attachment and hopefully restoring the hoop strength to preserve the joint's long-term health.
It's precisely that critical. This diagnosis marks the difference between potentially maintaining a functional knee versus one almost certainly destined for premature replacement down the line. #TAG 4.4 meniscal extrusion and instability. And the direct biomechanical consequence of a failed root or a complete radial tear extending to the periphery is meniscal extrusion.
Right, the meniscus getting squeezed out. How do we define that radiologically?
It's defined as the displacement of the meniscal body greater than 3 millimeters outside the edge of the tibial articular cartilage margin. This is best measured on the mid-coronal images.
That 3 millimeter threshold is basically the visual manifestation of the broken hoop stress, isn't it? The meniscus, unable to resist the compressive force, is simply being squeezed out from between the femur and the tibia, like trying to hold a wet watermelon seed between two fingers.
Exactly like that. It just pops out. And the correlation is extremely high.
Right.
Extrusion greater than 3 millimeters, highly sensitive, around 92%, and specific around 93% for medial meniscus posterior root ligament tears in particular. It's almost a proxy measurement for that functional failure.
So extrusion, or the presence of a clearly displaced fragment like a bucket handle, immediately meets the criteria for an unstable tear, right?
Correct. Those are direct signs of instability. Van de Berg and colleagues formalized the criteria for diagnosing an unstable tear, one that genuinely requires mechanical fixation or repair for stability. We know the displaced fragment and significant extrusion are direct evidence. What about the indirect imaging signs of instability?
Yeah, what else suggests instability?
First, size matters. The tear should ideally be visible on multiple thick slices, approximating a length greater than about 10 millimeter. A long tear inherently has less intrinsic stability than a small contained one.
Okay, length 10 millimeter.
Second, complexity. If the tear extends in more than one orientation plane, making it a complex tear, it inherently lacks structural stability.
Makes sense.
And the final piece of evidence involves looking closely at the fluid signal within the tear. The presence of frank, bright, fluid-like signal intensity on T2-weighted images is key.
Why fluid signal specifically?
Because it signifies that the torn edges are separated widely enough to allow the ingress of joint fluid into the defect. That visible separation indicates that the remaining structure cannot hold itself together adequately under load and will likely require external mechanical fixation, meaning repair, to restore stability. Okay, before we move on to treatment and post-op imaging, we absolutely must ensure we don't misinterpret normal anatomy or variants as pathology. Anatomic variants are crucial pitfalls. The most common morphological variant we encounter is the discoid meniscus.
Ah, the discoid. This is basically an abnormally enlarged, more pleat-like or disc-shaped meniscus that extends much further centrally into the joint than normal.
That's it. And this is overwhelmingly a lateral pathology. It's quite rare medially, maybe 0.1% to 0.3% incidence. But laterally, it can affect anywhere from 1.5% up to maybe 15.5% of the population, depending on the study. It's a common cause of pediatric knee snapping and sometimes instability symptoms.
So what are the MRI criteria for diagnosing it? How big is big enough?
The formal criteria look for a mediolateral width of the meniscus at the center of the body greater than 15 millimeters.
Yeah.
But the easier visual sign, the one most people use, is the central bow tie sign.
Right. That means seeing the meniscal body, that bow tie shape, visible on more than 2 consecutive 5 millimeter sagittal images. Since the normal meniscal body should really only appear as a full bow tie on maybe 2 central slices,
Exactly.
seeing it clearly on 3 or more consecutive slices means it's abnormally enlarged and therefore discoid.
Correct. And while many discoid menisci are actually asymptomatic throughout life, the classification by Watanabe is important. He described complete, covering the whole tibial plateau, incomplete, and the most symptomatic type, the Risberg variant.
What's special about the Risberg variant?
This specific type lacks the normal posterior coronary ligament, or capsular attachments, that usually anchor the posterior horn of the lateral meniscus.
So if those posterior attachments are missing,
The discoid meniscus becomes hypermobile. It can actually snap back and forth quite dramatically as the knee moves, especially during flexion and extension. That mobility rather than necessarily a tear within the discoid structure itself, is often what causes the patient's classic symptoms of snapping, clicking, or even locking. It's a dynamic instability that we can often infer from the static imaging if we understand the underlying anatomical deficiency. Hashtag tag 5.2 pitfalls simulating tears.
Okay, let's run through some of the other common diagnostic traps, the things that often lead to unnecessary surgical intervention because they look like a tear, but are actually just anatomical red herrings.
Absolutely crucial to cover these. The first one is pretty common, especially in the medial compartment, the meniscal flounce.
This flounce sounds elegant.
It does, but it can be confusing. This is basically a rippled or folded appearance of the free medial edge of the meniscus. It's often just a transient physiological distortion, maybe some redundancy of the medial tissue related to the specific knee position during the scan, but it can definitely mimic a radial tear on coronal images if you're not careful.
So how do you tell it's just a flounce?
Usually it looks like a smooth, symmetric fold, and it might change appearance on different sequences, or if the patient repositions slightly. Excessive or asymmetric folding, though, might suggest an underlying tear or displacement is causing the buckling.
Okay. Next up, we have those anatomical structures that cross the joint line and create confusion through volume averaging effects, starting anteriorly.
The junction where the anterior transverse ligament inserts into the anterior horn of the meniscus, this can sometimes be mistaken for an oblique tear right at the anterior horn. The key is to check your axial images. You can usually follow the path of the transverse ligament right into the meniscus and confirm it's just a normal structural insertion.
Got it. Followed on the axials. Then laterally, we have those meniscofemoral ligaments, right? The ligaments of Humphrey and Risberg attaching near the posterior horn of the lateral meniscus.
Yes, and their attachments can create a classic pseudotear. You see this high signal intensity band right between the ligament fibers and the meniscus itself. The signal is typically just due to volume averaging in this very complex junction, where three different structures, the meniscus, the ligament, and maybe a bit of joint fluid, all converge within the same imaging voxel. It looks like a tear, but it's just an artifact of the imaging process at that specific anatomical location.
Okay, pseudotear from the meniscofemoral ligaments. What about the popliteus tendon? That's another major culprit on the lateral side, isn't it?
Huge potential pitfall. The popliteus tendon sheath passes right through the lateral posterior horn via the popliteal hiatus, remember. Its path, and the fluid often within its sheath, can easily be confused with a peripheral lateral tear on the sagittal sections especially.
So how do you avoid that mistake?
The radiologist has to meticulously track the hypointense tendon itself as it moves relative to the meniscus in consecutive slices. If they don't carefully follow the tendon through the hiatus, they risk calling that normal anatomical gap a tear.
Okay. And finally, probably the most notorious non-tear that looks exactly like a tear, especially in the most commonly injured location, the magic angle effect.
Ah, yes, the bane of knee MRI interpretation sometimes.
The magical 55 degrees. This is the ultimate physics trap, isn't it?
It really is. This is a spurious, completely artifactual increased signal intensity that occurs when highly ordered collagen fibers, which are normally dark on sequences like PD and T1, happen to be oriented at precisely 55 degrees relative to the main magnetic field, B0.
And why is this such a problem for the meniscus?
Because the postcarrier horn and the root ligament of the medial meniscus often travel at almost exactly this angle as they sweep posteriorly and inferiorly to attach to the tibia. Consequently, that specific posteromedial corner is highly susceptible to this artifact. It can look exactly like a grade 2 or even a subtle grade 3 tear on short T&E sequences like PD or T1, but it's just physics, not pathology.
And that specific region, the posteromedial corner, is already the highest risk area for real tears. So the magic angle effect right there is a known common cause of false positive diagnoses and potentially unnecessary surgical exploration.
It absolutely is. It teaches us that image interpretation must always be filtered through an understanding of the underlying physics and its limitations. You need to confirm suspected tears in this region on T2-weighted images, where the magic angle effect disappears.
Good tip. We must also briefly recognize things like truncation artifacts, right? Those faint horizontal lines you sometimes see due to the Fourier transform methods, especially in lower resolution matrices. They can be mistaken for subtle horizontal tears.
Correct. And also partial volume averaging. This happens when the natural concavity of the outer meniscal edge gets averaged within a thicker sagittal slice, potentially mimicking a small horizontal cleavage plane right at the periphery. Knowing these physics-based limitations is essential to minimize iatrogenic errors based on misinterpretation.
Okay, now we move to the final challenge, imaging the knee after intervention. The traditional grading criteria we just discussed are largely invalidated now, aren't they?
Pretty much out the window, yes.
We're dealing with the 3 R's of management: resection, partial meniscectomy, repair, and eventually, in some cases, replacement, allograft or synthetic.
And imaging the postoperative meniscus is an entirely different beast, because we're no longer just looking for pristine black tissue against a potential bright tear line. We're looking for signs of healing or re-tear or failure in the presence of scar tissue, sutures, anchors, or maybe even foreign graft materials. Hashtag 6.1 partial meniscectomy, resection.
Okay, let's start with partial meniscectomy or resection. This is typically indicated for tears deemed irreparable, maybe complex tears, large horizontal tears, or tears deep in the avascular white zone. The surgical goal is always to preserve the maximum amount of stable meniscal tissue and create a smooth, stable remaining rim.
Right. And the standard post-resection MRI appearance is usually pretty straightforward. You see definite volume loss where tissue was removed, and usually a visible blunting or squaring off of the inner edge that was trimmed. You can clearly see the resected region, typically on sagittal and coronal images.
The major clinical challenge, though, is differentiating between normal postoperative scar tissue and a recurrent tear in the remaining rim, isn't it?
That's the crux of the problem. Post-resection tissue remodeling means that you often see hyperintense intrasubstance signal intensity, something that would normally look like a grade 2 or even grade 3 tear signal that may now extend all the way to the newly remodeled articular surface. But this is often just scar tissue filling the gap, not necessarily a recurrent unstable tear. Conventional criteria become very unreliable.
So we have to exercise extreme caution interpreting signal in the remnant. However, you mentioned radial tears earlier. Are they more common after resection?
Yes, interestingly, studies show radial tears are statistically more frequent in the meniscal remnant. After a partial meniscectomy, maybe 32% incidence compared to 14% in virgin knees.
Why would that be?
It likely highlights that altering the biomechanics, even with a successful resection, inevitably shifts the loading pattern onto the remaining tissue. This can make the remnant more vulnerable to new types of tears, particularly those radial ones that disrupt the remaining hoop fibers. So we must be highly vigilant for new radial tears or other signs of structural failure in the meniscal remnant on follow-up scans. Hashtag 6.2 meniscal repair, the gold standard.
Okay, moving to meniscal repair. This is really the gold standard for preservation when feasible, right?
Yeah.
Generally reserved for acute, smaller tears, maybe 1 to 2 centimeters, typically longitudinal peripheral tears located in that vascularized red zone, and often performed concurrently with an ACL reconstruction to optimize the healing environment with growth factors from the ACL surgery.
That's the ideal scenario, yes. Techniques vary, of course, but they all leave some imaging clues. The classic inside-out technique, using vertical mattress sutures, is often considered the gold standard biomechanically, placing sutures far out peripherally.
Right.
Outside-in techniques are sometimes used more for anterior horns to minimize the risk to the saphenous nerve. And the newer all-inside suture devices are often favored for posterior horns because they're faster, though they carry a small theoretical risk of device migration or irritation.
The primary struggle for us, the imagers interpreting the follow-up scans, is that conventional MRI is notoriously poor after repair, isn't it? Why is that?
It's because the signal abnormalities caused by the healing process itself, granulation tissue, scar formation, maybe some foreign body reaction to the suture material, can persist for a very long time, sometimes over 10 years post-surgery. This makes the repaired tissue look chronically abnormal, maybe bright or indistinct, even if it is functionally healed and stable.
So we absolutely cannot rely on the simple grade 0-3 grading system after a repair. How do we diagnose a true recurrent or remnant tear in a repaired meniscus?
We have to look for more definitive signs of failure. Specifically, we need to see frank, clear, fluid signal intensity within a distinct line extending to the meniscal surface, or a definite visible change in the configuration or morphology of the meniscus compared to the immediate postoperative baseline image. That bright fluid signal indicates a persistent mechanical gap or vacuum, allowing synovial fluid to enter the defect, signifying a failure to heal or a re-tear.
So fluid in the tear line is the key. What if suspicion is high clinically, but the conventional MRI is equivocal? Sensitivities for detecting recurrence can be pretty low, maybe only 38% sometimes.
If conventional MRI is ambiguous, then we absolutely must utilize advanced techniques. MR orthography MRI becomes indispensable here.
Injecting contrast into the joint.
Exactly. MRA shines because the direct extension of the gadolinium contrast material into the substance of the meniscus definitively confirms the presence of a surface communicating defect, clearly separating inert scar tissue from a true mechanical failure. Studies show MRA dramatically improves accuracy to somewhere between 88% and 92% for diagnosing recurrent tears after repair, providing the definitive roadmap needed for potential reoperation. Hashtag 6.3 meniscal replacement reconstruction. The future.
All right, for those patients facing the dire long-term consequences of extensive partial or worse total meniscectomy, especially younger patients, we turn to reconstruction options. This includes synthetic implants in some cases, or more commonly, meniscal allograft transplantation, MAT.
Right. MAT-array is generally reserved for symptomatic patients, usually younger, active individuals who have lost most or all of their meniscus, but, crucially, still have minimal cartilage damage, minimal arthritis on the corresponding femoral condyle and tibial plateau.
So good remaining cartilage is key.
Absolutely. The idea is to restore the load-bearing and shock-absorbing capacity of the knee by transplanting cadaveric meniscal tissue, which is usually anchored securely with bone plugs into the tibia to replace the function of the native failed roots.
When we're imaging a MAT post-operatively, what are the potential complications we're tracking over time?
Complications are unfortunately relatively common, reported around 21% or so. We track things like progressive cartilage loss, meaning the graft failed to protect the joint from developing OA. We look for allograft shrinkage over time, and also for arthrofibrosis, excessive scarring in the joint. But perhaps the most common and maybe the most complex imaging finding we deal with is allograft extrusion.
Extrusion again. We define that as greater than 3 millimeter displacement from the tibial edge. Is that finding always bad in an allograft?
Not necessarily, and that's the tricky part. Extrusion is an extremely common finding post-operatively with MAT, sometimes seen even in clinically successful asymptomatic cases. So it's critical not to immediately declare the graft a failure simply because it shows some minor or moderate extrusion.
Why does it extrude so often?
It's thought to be multifactorial. Maybe slight bone plug malposition during surgery, graft shrinkage over time, or perhaps the tension on the anchor points decreases, leading to this subtle displacement. The key is differentiation and correlation.
How do we differentiate?
Imaging the MAT requires specific attention to the degree of extrusion, whether it's progressive compared to prior scans, its position relative to the joint line, and critically, correlating it with the patient's symptoms. We're looking for signs that the extrusion is excessive or symptomatic, indicating true mechanical failure or instability, rather than just expected post-surgical remodeling or adaptation. We're really managing not just the graft tissue itself, but the functional preservation of the entire knee joint ecosystem. Hashtag outro. So to summarize this, pretty critical deep dives, the meniscus is a highly complex biomechanical structure. Its primary design feature is converting axial load into tensile hoop stress via those circumferential fibers. Any structural failure, especially those devastating root tears or complete radial tears that breaches this hoop mechanism, leads directly, and often rapidly, to catastrophic OA progression.
Right. And MRI, provided we adhere to those high-resolution optimized PD sequences we talked about, is clearly our best diagnostic tool for classifying the tear type, assessing stability, and planning the appropriate surgical approach.
It is, but the diagnosis demands an experienced eye, as we've seen. We must be acutely aware of the anatomical variants, like the discoid meniscus, and maybe most critically, all those technical and anatomical pitfalls.
You have to remember the popliteus hiatus pseudotear, the meniscofemoral ligament pseudotear, and that notorious magic angle effect, especially lurking at that high-risk posteromedial root, to avoid potentially recommending unnecessary surgery based purely on an artifact.
Exactly. The ultimate clinical takeaway, I think, is simple. Stability is paramount. The least mobile part of the meniscus, that posteromedial horn, is the most frequently torn precisely because it lacks the capacity to escape the load effectively. Our diagnostic determination of long-term knee health really hinges not just on classifying the tear pattern, vertical versus horizontal versus radial, but fundamentally on whether we successfully assess and, if needed, restore that vital hoop strength, primarily by preventing meniscal extrusion and functional meniscectomy.
That's a great summary point, and it leads to this final thought. If we know that even a successful partial meniscectomy increases the risk of developing late osteoarthritis 4 to 7 times compared to a knee with an intact meniscus, well, then the definition of successful meniscal treatment really has to evolve, doesn't it?
It seems it must.
It can no longer just mean short-term symptom relief. We have to start defining success by long-term joint preservation. And this realization forces us, and hopefully you, the listener, to consider the biomechanics first and foremost. So the provocative question is, what knowledge gap regarding load-bearing mechanics, cartilage preservation strategies, or maybe even regenerative approaches are you inspired to explore next after hearing all this?
Definitely some food for thought there for our listener.
Indeed. Thank you for joining us for this deep dive.
Until next time.